Larry Kempton. For those of you who don't know me, I'm one of the orthopedic trauma surgeons at CMC, and I'm introducing Dr. Todd McKinley for his talk today on precision medicine. I've known him since I met him in 2013 in Indiana, and he's been a great mentor to me since then. He's been an extremely prolific researcher, and I know some of his great successes in the past have been on articular fractures and patient outcomes from those, systemic indications of trauma severity in patients, and now he's moved on to this precision medication for trauma patients. He's been, like I said, a very prolific researcher, both with funding and with just the research itself. And I think his passion is one of the things that makes him so successful. And I think that's going to show through that, and you'll all see it when he's talking today. Without further delay, here's Dr. Todd McKinley.
Larry, thank you. First of all, thanks to CMC for the invitation. Thanks to everyone for being part of this. You know, it's like we were just talking about. It's challenging times, but we can all sit around and talk about how challenging it is or adapt to it. So, you know, these virtual presentations are reality for a while. So I do appreciate the invitation and the opportunity. And Larry, it's good to see you. Larry and I were partners for probably, about 4 years, I'm guessing. So my full disclosure here is I'm not exactly technologically savvy. So if someone has a question, I'm not sure how to answer the raised hand things or something like that. So write your questions down. I've left some time for discussion at the end. So I'm going to, I'm trying to see, is my screen up by any chance?
Yes, sir. It's up, but it's not in presentation mode at the moment.
Okay, so all right, so I just put it into, so now is it up in presentation mode?
Perfect.
Okay, yeah, all right. So, all right, once again, thanks for the opportunity. Here's my only disclosures. I get a check for every 3 months. I get a check for somewhere between 50, although this last month it was $112 for these retractors. And so I figured I'm making about $250 a year on these retractors. So I can go out to dinner twice a year in my conflicts. It doesn't really apply to this talk. But if anyone's looking for a good home-like retractor that you can pound into bone, I got a great one. Before I get going, here are the people that what I'm going to present today is a kind of a summation of some research we've been doing for the last, probably 7 or 8 years. It is culminated in a grant from the DoD, which is part of the metric, of which you guys are participating on, or one of the sites. And I've spent a lot of time with Dr. Rachel Seymour and Larry and the people there, and certainly with Dr. Bossy, and not only developing the protocol, but executing it. So today I'm going to be presenting some of the foundational data. Of course, my pager goes off right then. The foundational data that led to it and kind of the approach. And so you can see the for the study. And these are the main collaborators. So Greg Gasky, who also used to be my partner before, both he and Larry quit and moved other places. Greg's been a tremendous colleague and partner on this. He's in Inova in Northern Virginia now. These are the people in Indiana. Is the mouse working here or not? I'd love to know if you can see the cursor floating around.
Yes, we can see the arrow.
Oh, that's outstanding. So anyway, I'd like to thank my whole team here, and especially Krista Brown, who's our lead coordinator. Mark Kaplan is the head of immunology at Indiana University. He's become a great colleague with this stuff. Collaborated closely with the people at the University of Pittsburgh, and certainly want to point out Doctors Billier and Vodovats, who've become not only colleagues, but true friends. And a lot of the work I'm going to show today, these guys are the true pioneers of this work in a lot of ways, some of this immunologic stuff. And they've probably the most published people there is pertaining to this stuff. And this is their team. And then we're also working closely with some people at Uniform Services, particularly Eric Elster, who's their head of surgery, and Seth Schobel, who's their head computational biologist there. So anyhow, this is, I'm going to throw some theoretical models out here. This is just a theoretical model of almost any disease, and it can pertain to a surgical disease or a medical disease, whatever you want to call it. And so anyhow, here's where if someone comes in and they got a problem, so your disease is detected, and before a disease is ever detected, there's certain things that play into it. There's your genetics, and then transformations in your genetics. There's your habits and lifestyle and your demographics. And then there's this period of time where the disease starts and it kind of festers, then it finally manifests itself. And then we as doctors, we pick up on what it is and we intervene, and there's a response, and then we see how we're doing. There's some real unique things to trauma. And one of the unique things to trauma is this section right here is gone. So all the information you can gather on a patient and all the research and all the information that people have tried to generate over the years in this space right here, you come to trauma and that space is gone. And that's probably a hazard and an opportunity, to be honest with you. And so with trauma, the onset of the disease is rather abrupt. And, once again, when we make treatment decisions, all these things play into our treatment decisions. We intervene and we respond. And this is kind of a theoretical model of trauma if you look at this. So the x-axis here is in seconds. It's a log axis in seconds. Okay, and the y-axis, I have it going down because I'm just calling this kind of a overall physiologic status. And before you get hurt, here's your injury right here. Before you get hurt, you're at your baseline physiologic status. And if you get hurt badly, that changes rather abruptly. And you're probably bleeding here. And if you get hurt too badly and that red line goes below somewhere down here, you die. And so anyhow, but this is, so this is a hypothetical, model of injury. You get worse and then you get better, and you might be left with some disability out here. So what do we do as surgeons? We intervene. So someone comes in and they hurt, and this intervention here is probably a hemorrhage control operation. And what's interesting about trauma, more so than a lot of diseases, we have these titrated subsequent interventions. And these are the things that the orthopedic surgeon, these are the interventions that we're very familiar with, these titrated interventions. We come in here sometimes, but this is primarily general surgery in here, maybe some damage control orthopedics. But these decisions and these interventions are fairly rapid here. Orthopedics might have 2 or 3 of these arrows out here, depending on the patient. And then the other services certainly have interventions out there also. Sometimes it goes like this, though. So we stop the bleeding, and then there's another reconstructive or titrated intervention. Somebody gets really worse. And as to why this happens, there's been a lot of research to try to figure out why this happened. And the precise study is to take patient information and optimize these decisions, both the timing and the choices of these decisions. So if you look at this, your physiologic status and how you do after injury is probably a function of the injury magnitude, your to injury, which is kind of a garbage bag term or a grab bag term I'll get into, your genetics and your demographics. And if you look at these things, all these things are technically and should be feasible to actually measure on a patient-specific basis right here. And that's some of the foundation of the study. And then we intervene. So these interventions, how they help you are probably a function, and this is not a complete list, this is my thinking, is the magnitude of surgery and the timing of the operation, what you actually accomplish. And anyone in this audience who's a surgeon at one time in their life has said, that's a big operation, not much of an operation. And other than one publication in the spine literature in 2016, I can't find one publication in PubMed that actually tries to measure surgical magnitude. And so once again, these things can be probably quantified on a patient-specific basis. So if you think about interventions in trauma, this kind of is a generalization. First of all, the emergency decisions sometimes got to be made in a scale, sometimes maybe double-digit seconds to single-digit minutes, and there's not a big window to gather information to make those decisions. So these are generally based on population models. So what we know, if you're bleeding to death and your heart rate's 180 and your systolic pressure 60, that's kind of the population says that patient needs hemorrhage control. However, like I say, a large amount of the care that these patients get is it's titrated. So you do hemorrhage control, and then these services, the general surgeons, the orthopods, the neurosurgeons, and the ICU team, they're surgical or non-surgical interventions that are chosen after this. And the way I look at that is that really opens up these opportunities to further study these things that we might be able to measure. And so I look at this, and this is what I would call the immediate decision window. And it's right now, it's hard to inform this window with a lot of patient information. Doesn't mean it can't happen, but this window probably is at least this wide right now. And then you got this titrated window. Is there information we can gather that's specific to the patient to better inform what and when these interventions take place? This is a model for orthopedics right here, and this is kind of how we go. And this would be titrated orthopedic care. This is a CT scan, obviously, with a broken, you got a broken hip, you got a broken shaft, and you got a hip socket fracture here. And and this patient comes in. If this patient is physiologically stable, we got good population norms that early appropriate care is safe and effective and cost effective, and the patients do better. This patient's out here in extremis. It's a horrible idea to take this patient in and do 6 to 8 hours of bone surgery to try to put all this stuff back together. But there's this space in the middle here, and part of the rationale for the PRECISE study is try to understand these spaces on a patient-specific basis to truly understand the best timing of interventions and the best interventions. And the way we do that is by measuring the injury and measuring the response to injury. So, and here, once again, I just kind of got this model put out. Here's your immediate and your titrated window of information. And these are trauma and orthopedic based outcomes and when decisions are made, and you can see once again on this logarithmic scale that, if decisions are made well, you can resolve these things and avoid non-unions and avoid infections. So this is an outline in some ways of the PRECISE study, okay? And essentially, and this is an outline that I put together. Actually, I think Greg Gasky made this slide of a conceptual outline to precision trauma care. And so, this is what we're kind of calling your precision trauma signature. And this is informed by several things. It's informed by genetic information. It's informed by your habits up to that period in your life and just your basic demographics. That's informed by your injury, and it's informed by your response to injury. So all these things, and this probably isn't even complete by any means, but this is the concept we're working around. And so you have this precision trauma signature. And these things, and then you intervene and there's an outcome. And so we're looking at this as how much of this stuff in here, including the outcomes, can be measured on a patient-specific and a precise basis. So the first thing we did, and this is where some of this started, is, I don't know, probably a half a dozen years ago now, Greg Gasky and I came up with this idea of measuring injury. We always say, well, that's a big injury, that's a little injury. It's like, well, how do you measure an injury? And so we looked at it and we said, okay, well, we get imaging of all these injuries, so let's just measure it. So we're going to measure the mechanical tissue damage. And so what we did is we went back on a retrospective cohort of patients, and essentially we did this first, Nadia. Now we got computer software to do this, but essentially what we did is we went to their pan scans and we measured every injury in their body, and we've got software that will go around these injuries. Like this is a retro, a pelvic and a retroperitoneal hematoma. So we would go to the pan scan and we would literally measure every cubic centimeter of either parenchymal tissue damage or hematoma that was in the body. And then the question was, does the quantity of injury, does it correspond to any outcomes? And we started with a retrospective population of 80 patients. And we looked at that, and this just shows, like in this case, here's a hemothorax segmented out here. And so we could look at this and say we got maybe 122 milliliters of tissue damage in the lung. And so we looked at this, and this is in a retrospective series of patients. And we published this, God, it must be at least 5 years ago now. And what we found is that there were kind of modest at best correlations with this high spread in the data, as you would expect, between whether you had multiple organ failure or not. I think we used the SOFA score, and we took the CNS component out of it. But the one thing we saw is that the magnitude of tissue damage in the pelvis and then the overall tissue damage, which probably just reflects this, corresponded to organ failure as our outcome. So we tried to do that prospectively, and in a series of 100 patients at Indiana University, we did the same thing. We kind of found the same thing. Once again, that the patients, and this we used the Denver scale, the patients who had multiple organ failure had higher magnitude of tissue damage volume in their pelvis. But once again, you know, I didn't get the deviation. The deviations are high and the correlations were loose. And what was clearly missing in this is it's one thing to measure mechanical damage, but it didn't account for ischemic tissue injury. And so we kind of went back and said, okay, what is there a way we can measure ischemic tissue injury better on a patient-specific basis? And so we came up with this idea of what's the where's a data stream on these patients that might be specific to the patient and how they respond to injury. And the one thing that all these ICU patients have are these string of vital signs. And so went back to the literature. And so instead of taking a static sample like we typically do now, where you calculate the lactator, you look at acid-base balance or surrogates of that here, went back to the vital signs and said, okay, and there's been this renewed interest in shock index values over about the last 10 years. And there's a lot of literature on shock index, and which is simply just a ratio of your heart rate to your systolic blood pressure. And there's pretty good literature support for if that gets to 0.9, you might be a little bit hypoperfused. You get into these regions, you're getting more hypoperfused, and there's no debate here. And so we went back and said, okay, why don't we use this shock index, since we got a lot of information on each patient. This is a theoretic model. So these are shock index values on an ICU patient. You know, on an ICU patient, you're typically getting vital signs maybe anywhere from 4 to 8 to 10 times an hour, depending on how badly hurt they are. So you can get this series of hemodynamic information on your patient. And if you put a threshold line in there at 0.9, and then you use a calculus and integrate this area above that threshold value, you can start getting a patient-specific measure of a surrogate for ischemic tissue injury. And this is the details on that. You know, you make assumptions from the time periods, you get your average shock index in between the time periods, and it's a pretty simple linear calculus for this. And so we looked at this, and we took our series of 100 prospective patients, and we looked at shock, and the shock volume, if you look at it, you can calculate the shock volume over any time period you want. This is in minutes here. And we looked at it like in a 6-hour block, and we looked at 12 hours of it, and we looked at 24 hours of it. And so then we looked at this and what our outcome was. So the question was, does this magnitude of ischemic tissue injury, or this patient-specific measure of your vital signs, how does it correlate to outcomes compared to, like in this case, base deficit or your pH? And I wish we had lactate here, but we just don't measure lactate much at our institution. So we use base deficit, we use your worst in your first base deficit and your worst in your first pH in the first 24 hours. And interestingly, it's not remarkably better, but it's certainly not worse, and it's probably a little bit better if you look at correspondence to organ dysfunction. So this shock volume, which is a patient-specific measure of tissue injury, actually is a pretty good predictor of what may come down the road. And so right now, those are the two things we're going to inform the PRECISE study, where the sites are sending us all their PAN scans, and one of the clinical research forms gets all these vital signs, and we're calculating this, which will be used in the models in this PRECISE study. So if you go back, that's kind of half the equation. So we just talked about measuring injury here. Now the question is, and this is where a lot of research has been, is how do we measure this patient-specific response? Let me find, and this is something that people talk about all the time, the response to injury. How'd you respond? And it's an unbelievably complicated space. And right now there's been a ton of stuff measuring the immune response, and typically it's the immune response. The way you measure it is the surrogate of the circulating mediators. There's a overwhelming body and a very informative body of research has been done here, but these things are coming, especially this one. And this is, I wouldn't say it's ignored, but there's a huge opportunity space here as people get further into this. And I wish our study had more money and we would have been collecting this, but we're not. But anyhow, if you look at the trauma response, I'm kind of diverging here, it's complex. And the immune response, what's interesting about it, if you think about it from an evolutionary standpoint, Immune response is essentially a one-trick pony in a lot of ways. It's had about 500 million years to figure out how to prevent infections in multicellular organisms compared to germs. And if you look at the evolutionary, pressure on trauma, you figure trauma, the way we look at it, it's only been around about 9,000 years. If you look at this and you do the math, so the bottom line is your immune response has had about 180,000 times more time to learn how to fight infection than to mitigate polytrauma. And so one thing that we know is oftentimes your immunologic response can go awry in these patients that get injured. This is a kind of a summary slide. There's components of the immune response that I think we're all somewhat familiar with. And the one thing that I think is important is that the cells that enact this, which go far beyond your white cells, they talk to each other primarily by chemicals. There's some cell-to-cell interactions, but there's a lot of chemical communication. And it's these chemicals that we measure that tries to give us some semblance of what's going on with an injury. Like here's an example from one of our studies. In that shock volume study, we looked at various, these are kind of the 4 immunologic mediators really associated with trauma, 6, 8, 10, and MCP1. And as you can see, the more ischemic tissue injury you have, the more shock volume these things go up, and there's plenty of studies that show that. Here's some work we did with the Pittsburgh group, and we just published this, and this is the magnitude of extremity injuries and how it corresponded to these immunologic mediators. And once again, the patients that get hurt worse or have worse injuries have higher, in this case, an anti-inflammatory mediator, lower concentration of these mediators. Here's some other work from the University of Pittsburgh, and this corresponds to organ dysfunction. The same kind of moral to the story here. These patients in the open circles had worse organ dysfunction after injury, and the red triangles had better outcomes, and you can see that the immunologic mediators are high. And so it just leads to, the obvious model is this. You get hurt, the mediators go up, you block the mediators right here. Unfortunately, this exists somewhere within here, and that pathway might exist right here. And what's interesting about this, Greg Gasky did this. He looked up and searched the literature and found a review. In the last probably 20 years, there's been 162 clinical trials in humans to try to mitigate the polytrauma response and improve things by a targeted intervention on one or several immunologic mediators. As far as I know, this is the last picture ever taken from the surface of the moon before Apollo 17 came back to Earth. And what you see in this picture is absolutely nothing. And that's the results from these 162 trials. That's essentially 0 for 162 to improve a trauma outcome by doing this. And so, so one has to ask himself, it's hard to bite the head off the monster. I think they've done it a little bit in rheumatoid arthritis, but no one's been able to do it in trauma. And so if you keep beating the same dead horse, it's going to lie there dead. And so these new approaches have really started to emerge in understanding the trauma response that essentially say, okay, we can't just look at isolated pathways. We got to look at a more broad kind of investigation of this trauma response. Unfortunately, electrons are really cheap and electrons are really fast. And with high-speed computing, people have developed some interesting ways of doing this. Here's an example that I want to show. So these are data from Pittsburgh's group, and this is 476 multiply injured patients. And the darker it is, the worse your organ dysfunction is. And you can see that there's a group up here that had more organ dysfunction after an injury. This is kind of called the intermediary group down here. And this group in the middle here is called the low organ dysfunction group. Now these patients are hurt worse than these patients, but not by a ton. Okay, but there's no question that injury severity explains a lot of this. But what's interesting, so if you look at their immunologic mediators, this is where Jorm Vodevats is really pioneered a lot of this. He's gone to these dynamic network approaches. So essentially, you measure all the immunologic mediators, and it's multiplex technology. So you measure probably, I don't know, maybe, in this case, I think they measured 44. And instead of looking at individual mediators, what you do is you start looking at how these mediators work together, or you're looking at the orchestration of these mediators. And this is a real simple example that I just drew out. Like, say these nodes are immunologic mediators, and here's time 1, and then you measure them again maybe 8 hours later, and maybe here's 8 more hours later. And if these things are mathematically coupled, when you measure this, they get an index of connectivity. And this is a very simplistic way of looking at it, but you can dial in how exact this has to be, and you can form these dynamic networks. And so you can figure, instead of looking at individual mediators, you look how connected they are to the other mediators. And this is where the story gets interesting. So if you go back to this group, you got your high organ dysfunction, your mid, intermediate, and your low. And if you come here and you look at how those immunologic mediators coordinated with each other, here's what it looks like. So here's the low organ dysfunction group. Here's the high organ, here's the high organ dysfunction group, and here's the people in the middle. And so and each one of these is a cytokine or a chemokine, each node here. And if there's a line drawn between them, that means that they are connected, or they're orchestrated together, or working together at least mathematically. And now the differences become somewhat striking. So what you can see here is the group that resolved their injury. They had this very coordinated early on, right after the injury. They were able to orchestrate their immunologic response very robustly compared to these groups. And over the first 24 hours to 48 hours, this highly orchestrated network of mediators just dissolves. In contrast, look at the group that got bad organ dysfunction. Not very coordinated from the get-go, but they have this delayed immunologic orchestration, which plays out here, almost a diametrically opposite response in their ability to coordinate their immunologic response based on their immunologic mediators. So we went back and looked at some of our data. So this is from the shock volume data. And if you look down here, this is time. So this 0 to 8 hours means, so we measured cytokines at 0 hours and 8 hours, and we see if they were coordinated in that time frame right there. And this is between 8 and 24 hours, and then 24 to 48. These patients didn't bleed very much. These patients bled a lot. And what you see, you can see there's 10 connections over here in the first 24 hours, where over here there's just 2. So the same idea. And then delayed, the patients who were hurt worse start getting connections back here that are delayed. One thing else to look at, and this is what's really striking right now, if you look at some of the constituents of these networks, and I'll come back to this here in a couple slides, but they're different constituents. Here are those inflammatory mediators, IL-6, 8, 10, and 1RA. And if you look at these mediators, these IL-21, 22, 23, 9, and these, there's an interesting story probably emerging here. Here's the same thing with patients. You know what, I'll just skip the slide. It kind of shows the same thing. These are patients that were coagulopathic when they hit the door, and patients who weren't coagulopathic, but the same thing. You see more networks early and these inflammatory networks here. And what's interesting is there's some literature that's really kind of emerging over the last 10 years that these 6 mediators right here, IL-9, 17, and 21, 2, 23, and 33, are very cytoprotective, especially in your boundary organs, your lung, gut, skin, and your endothelium. So these interleukins here, these mediators are highly found on the surface of these boundary organs that really get exposed during injury. And these are your inflammatory mediators. And if you come back here, the patients that get better early or don't get hurt as bad express those boundary protective cytokine clusters. We just got this paper back under review, and it's in for minor revision, so we should get this published. And it's the same thing between the Indiana patient population and the Pittsburgh patient population. That once again, the same kind of story here, that these boundary protective cytokines, the red lines here are the patients that got hurt really badly. These are the patients that didn't get hurt quite as bad based on ISS. So you can see the black ones are mild injury. The red ones are, or the green ones are moderate injury. Once you get your ISS above 25, those cytoprotective cytokines just are muted throughout here, and you can see where they diverge over here. So one more thing, and then I'll finish up here. And this is something that that we actually just got accepted for publication, Journal of Trauma. So this goes back to the Indiana cohort of patients. And if you look here, this is again that cumulative hypoperfusion, the shock volume is what you're looking at on the x-axis here. And then on the y-axis is organ dysfunction. And what we learn with our organ dysfunction is we take your organ dysfunction scores from day 2 to day 5 when we average them. And there's almost a line in the sand where if your day 2 through 5 average is above 4, that you don't do well. And if you look over here, like how many days you spend in ICU and how long you're ventilated, and if you get nosocomial infections, you can see there's a fairly stark line in the sand at above 4 and less than 4. And so we looked at this, and initially it's like, well, who are the people that screw up and only make this 0.49 instead of 0.8? And you got this group of people here that had a lot of shock volume, but really didn't get sick. And then you had this group over here that really didn't bleed nearly as much, but they got really sick. And so instead of looking at that as adversity, it's like, well, maybe there's something different about these patients. So initially I thought, well, these are probably young and healthy because the age group went from 18 to 55, and these might be old, but it's not the case. So we came and we looked at that. And so we called this group the shock sensitive group and this group the shock tolerant group. So we came back and looked at this, and so we went back and looked at some basics, and here's the entire cohort, and here's the sensitive, and so there's really not much age difference there. Genders are about the same. ISSs are functionally about the same, statistically not discriminating, but only 2 points apart, both pretty hurt. And so there's really nothing that discriminated about them here. So then we thought, oh, the other ones must have hit their head. We'd already gotten rid of all the severe TB we even looked at these data, but here's the TBI data here. So you can see that they came in about the same. The ones that had really bad when they hit the door about the same, and they all resolved. So if you come back here, this isn't explained by demographics or brain injury. And so then we went and we did these dynamic network analyses, and this is where I think the story gets really interesting, is if you look at this, so these are the cytokines again right here, these nodes. And the lines mean that the cytokines are orchestrated together. This top row are the patients who are sensitive to shock, and the bottom row is the patients who are tolerant to shock. And you can see in the first 8 hours that this is a bit more orchestrated than this, but look at this cluster right here. And then if you get to the 8 to 24 hour time interval, this is an inflammatory cluster that kind of exploded in the patients who were sensitive to shock. This cluster further even developed here. And if you look closely at that cluster, it's those 6 cytoprotective cytokines that are in that cluster that formed and coordinated very early in the patients who are shock tolerant. And by 24 hours, there's only 2 connections. I think there's 14 connections in this group and only 2 connections in this group. And so in summary, looking at this, I think it's fairly decent evidence that there's so much more to this immune response than looking at individuals, that the patient, as we try to understand this and decipher it, that these computational methods and trying to truly understand the immunologic response to trauma on a more global scale and understand coordination and orchestration is going to be important. And then also understanding how these things may interact with the other response systems in your body. Bringing it back to orthopedics a little bit, these are 19 patients from the same cohort that had femur fractures. And Greg Gasky looked at this, and the question was, some got, immediate femoral nailing, some were staged. Now, these patients who were staged were hurt worse. I mean, if you look at this, here's the patients that had damage control orthopedics, so they're hurt worse, and the ISS here is 40. That's a pretty hurt group. But the patients who had immediate fixation were hurt also. I mean, they're 30, and the demographics are roughly the same, but it's kind of and you can see the pH and stuff is different, but it's kind of you can see the patients, the damage control, they had their definitive nailing somewhere around 3 days, and the immediate group had their definitive nailing somewhere in the first 24 hours. And again, so what we did is we looked at these cytokines, what they did after definitive surgery. So this isn't from the time of injury, but this is what happened to those 6 reparative cytokines after definitive surgery. So this time point right here is probably somewhere within the first 24 hours in the EAC patients. This is somewhere out around 72 hours. But you can see femoral nailing had a fairly predictable effect on those reparative cytokines when it was done early, or it didn't really bump them out at all here. So not sure if that's a timing effect or if it's effect of injury severity, but it's interesting that there's a distinct feature difference between how these reparative cytokines behave under different clinical manifestations. So spend the last few minutes just talking about the PRECISE study. And so that's a lot of the background for the PRECISE study. So to summarize that, we've come up with these precision ways to try to measure surgery or to measure injury and measure the response to injury. We're also coming up with some new ways to try to measure surgery, which is essentially uncharted territory in a lot of ways. So that's kind of an exploratory aim. So we're going to enter 400 consecutive multiply injured patients, essentially saying that and they got to have a qualifying orthopedic injury. And you guys are familiar with this. And we're going to be measuring the index of injury, like I showed, the mechanical tissue damage and the ischemic tissue damage. We're going to use computational approaches to measure the immunologic response. We're going to be integrating demographics and genetics into this also, and then we're going to try to measure surgery. And so there's 3 hypotheses. So the first hypothesis that we're going to test is that there's patients that have just fundamentally different immunologic responses, which may affect outcomes. And so we're going to measure this stuff, we're going to measure this stuff, enter this stuff into this patient precision injury signature, and then we see how they responded to the injury and if that corresponds to the outcomes. So essentially trying to take measurements specific to the patient and then seeing how those correspond to how they respond and if that predicts outcomes. The second hypothesis is this. And this is, and so there's always this question, should the patient have damage control or should they have early appropriate care? And in this study, this study isn't used to tell you what to do. The surgeons are going to make decisions between the general, the ICU, the neurosurgeons, the orthopedic surgeons as to how the initial care and then subsequent care is titrated. But we're going to see how patients do. And so we're going to use all this patient-specific data that we're collecting, use the demographics. They're going to have a patient-specific injury profile, and then we see how they respond to these surgeries. And we're looking at the outcomes we're looking at are this cumulative organ dysfunction, infections, wound complications, and resource utilizations. And then finally, the last thing in the PRECISE study, this is kind of exploratory. And once again, I say everyone's always said, oh, that's a big operation, or that's not much of an operation, and no one's ever measured it. So we're starting this modeling exercise on trying to actually measure surgery. And this is a conceptual, very 30,000-foot view, conceptual view of this. But the things that will inform the surgical magnitude will be the obvious things, the duration and the blood loss and the transfusions. And these will be in the orthopedic operations. The other things that we'll use to inform them will be, change in stability and what was accomplished in the operation. And so we've just on the front end of this modeling exercise. So part of the PRECISE study is you will be capturing and entering data to describe, and hopefully we can model the magnitude of surgery. So that's probably it. I think there's 15 minutes left for questions, and I appreciate everyone's attention. So I don't know if I can unshare my screen, and I'm happy to entertain any questions.
Dr. McKinley, in our region, we're fortunate to have multiple trauma centers, and a few of them are listening right now. If they're interested in learning more or participating in the study, what's the best way of doing that?
Well, participating in the study at this point would probably be really, I don't know if it's feasible, but boy, if it was, it'd be great, because COVID has really put a hamper on enrollment. I think right now we're probably at 145 out of 400 enrolled. And it's administered through the metric. And so you have to actually be a metric site. And Carolinas has been a very robust metric site. and has been a great contributor over the years, and you know, obviously a lead site with Dr. Bossy, the head of the metric. And so you have to be a metric site to participate in it. So I'm not sure if there's opportunity for sites that aren't part of the metric to participate.
Thank you, Dr. McKinley. This is Rachel Seymour, and I just thank you for sharing this with everyone, and just say that we're very proud to be part of this effort. We're looking forward to being able to restart sometime soon. And I would probably echo what you said. I think this is a particularly challenging study to participate in. We've been very fortunate in orthopedic surgery to partner with the trauma research group as well as the emergency medicine research group. And we really would not be able to do this without all three really strong research teams. But for some of you out there, we will be looking to you to get more involved in some of our other metric projects, probably just not this one.
Yeah, no question about that. And I want to, Rachel, good to see you, by the way. It's nice to see everybody. This you know, metric, and a lot of people on this call, I'm sure, are familiar. It's the Major Extremity Trauma and Rehabilitation Consortium. And this is probably one of the first studies in metric where I think, you know, Dr. Boss and I had this conversation probably 6 or 7 years ago, and I floated the idea to him that the lifeblood of metric, in my opinion, and that of others, needs to expand. And you know, we have these lines drawn. Well, there's general surgery trauma and orthopedic trauma or neurosurgery. I don't think those lines exist. In fact, I ignore those lines. And this is a great study for orthopedics and general surgery to work together on, you know, and it's working well in our hospital. And the other thing is, any of these data are going to be available for any of the participating center sites. And so the bottom line is, we're going to have dense biomarker data collected, certainly for the first 48 hours and probably up to 5 to 7 days, on 400 patients with very precise documentation of their injuries. So if there are people on this call that are part of the study that have interest in other investigations where those data may help out, you know, it's just simply an application of the Science Committee of Metric and a white paper and negotiating with the metric. And there's a tremendous opportunity of data here for people who may want to use it too. So I think it's a great opportunity for orthopedics and general surgery to work together. And critical care, you know, and neurosurgery too. So, other questions? Well, I thank everybody for your attention. Not sure what's going on at your site. You know, unfortunately, I think things are going to probably slow down again here for a bit, but hopefully the announcements over the last couple of weeks from these people that have, you know, really put their heart and soul into try to get a vaccine for this god-awful thing, it's going to work. So I'm an optimist. So hopefully it'll be sooner than later that we're all back in business here doing this. So, Larry, thanks. Rachel, good to see you. Scott, thanks for the help on this, and I greatly appreciate the opportunity.
Thanks a lot, Todd.
Great, thank you.
Okay. All right, thanks, everybody.
Bye.